Good day, everyone. My name is Viktorova Ekaterina, and I am the Scientific Director of VetStem Company. We are pleased to welcome you, both those present here in the hall and those watching us online. Today, the topic of our lecture concerns anesthesiology. This lecture will be delivered by a great speaker, a leading veterinary doctor, anesthesiologist and resuscitator. Vet City Clinic, Olenchuk Stepan Stepanovich. Hello, Stepan Stepanovich. It's your turn.
Hello again, colleagues. Thank you for coming to our lecture today. Today we will talk about anesthesia, anesthesiological support, and specifically the drug Vesotil, accordingly, which is produced by VetStem Company. This is a new product on the veterinary market. Today's discussion will focus on the utilization of Vesotil and its compatibility with various medications. Let's explore how Vesotil can be used in combination with other drugs, and what effects we can expect from this particular drug. Today we will be discussing the management of anesthesia, including its components and the various drugs that are typically utilized for this purpose. And what are probably the most significant subtleties exist in anesthesia, particularly concerning the application of inhalational anesthetics. Discover the affiliation of Vesotil. Today I will provide a thorough explanation of what it entails and its distinguishing characteristics. VetStem's medication provides superior results in general. Allow me to reiterate that our preferred anesthesia technique, referred to as the anesthetic triad, consistently includes a combination of two key components. Quality anesthesia cannot be achieved without this essential component. We must have three components. One must definitely be sleep, that is, animals just like humans must be asleep, feel nothing. They should experience a temporary memory lapse post-treatment such that they remember nothing that occurred during it. Once again, this is done to further diminish the stress that is inherently connected to it, how we carry out the procedure that we do. Also essential, meaning it's an integral part of the management, is analgesia. The animals must not experience any discomfort or pain whatsoever resulting from the procedure, and the quality of the anesthesia we provide is contingent upon this. We also require muscle relaxation for the animals to help with their recovery. In order to achieve full relaxation, it is important for all muscles to be completely relaxed. This helps, first of all, with positioning them on the operating table and with the surgeon's manipulations, for instance. If it's orthopedic work or cutting the abdominal wall, it also prevents injuries. Regrettably, there are instances where animals lack relaxation and we secure them to the table using specific restraints. And if we have this muscle tension, joint issues, for example, if we observe hypertonicity in the animal's joints, to ensure proper positioning, we anchor the animal securely to the table to prevent any movement during the procedure. If the animal has pre-existing joint pathologies like arthrosis, particularly in elderly animals, they may experience discomfort. All of this can lead to injuries. After the surgery, you might not even grasp what has happened to your patient simply because they were insufficiently relaxed during the procedure. Secondary injuries occurred due to improper positioning, and inadequate muscle relaxation could have been avoided with proper care and positioning techniques. Additional information regarding the components required for optimal anesthetic management. What options are available to us? What are the preferred medications for maintaining our anesthetic triad in optimal conditions? When it comes to attaining sleep, inhaled anesthetics are considered the most innovative choice among various options available nowadays. There are anesthetics with few side effects and even beneficial properties for us, like sevoflurane. These drugs are highly effective in managing pain and ensuring a smooth surgical experience. Offers cardioprotective qualities, giving us certain additional benefits besides ensuring deep sleep in the animal. We possess additional types of medications that can be applied to bring about different levels of sleep induction. These include barbiturates, benzodiazepines, alpha-2 agonists, along with dissociatives and propofol. Consider a key point. As we know, unfortunately, barbiturates and benzodiazepines in our country are only available with a special license for the use of narcotic and psychoactive substances. So for the majority of individuals, and incorporating them into our daily routine may prove to be challenging for us at this time. Propofol is meant to be administered exclusively through intravenous route. It provides a sufficiently good deep sleep, and the depth of sleep is regulated by titrating the dose. This is likely the initial drug that anesthesiologists administer. It is widely used in practice and easily controllable. Novice anesthesiologists rapidly become accustomed to using propofol and learn precisely how to control the depth of sleep by titrating the propofol dose. When it comes to the alpha-2 agonists and the alpha-2 adrenoceptors, we are talking about dexmedetomidine and medetomidine. These are among the modern agents accessible to us in veterinary practice today. They bring about sleep with varying effects depending on the dosage administered. Unfortunately, in order to achieve the necessary level of sleep depth with these medications as the sole form of treatment, we have to administer elevated dosages. And the use of these large doses leads to the development of more pronounced side effects, such as bradycardia and arterial hypertension in the first phase when we first start applying these drugs. Regrettably, they are not appropriate for monotherapy sleep induction, yet they work beautifully as a sedative option, proving to be wonderful in that aspect. The proper administration of anesthesia is a crucial component of our overall medical care. That alpha-2 agonists, they actually induce what we might call physiological sleep, thereby encouraging its onset. That is, the more physiological the sleep, the better the animals usually recover afterwards. And the quality of our anesthesia, the sleep component of sedation, it will again reach a completely different level, rather than what might be some kind of terrible medicated coma. When it comes to analgesia, the absolute cornerstone in anesthesiology for both veterinary and human medicine, opioids are recognized as key analgesic agents. These drugs interact with opioid receptors in the body for their effects, and they constitute analogs of the body's own endogenous pain-relieving molecules. So, a large number of them are found in different parts of the nervous system, and therefore they work on different parts of nerve impulse transmission, specifically the pain impulse, and have wide use. As you are perfectly aware, since these are narcotic substances, both morphine and fentanyl, in daily practice a license is necessary for using butorphanol, ensuring compliance with regulations. For most people, at this moment, these options are not accessible. To alleviate pain, we can utilize local anesthetics such as lidocaine, bupivacaine, and ropivacaine. However, they are currently unavailable. One example of their use is epidural anesthesia, while regional anesthesia can also benefit from them. The applications are wide-ranging and constantly evolving. The utilization of blocks guided by ultrasound is extremely common in anesthesiology. These medications are also utilized in the field of animal dentistry. Local anesthetics and nerve blocks can be administered using ultrasound guidance or a nerve stimulator for effective pain management. We are able to guarantee a rather effective level of control over the pain and consequently to virtually disable any bodily section, yes, meaning a specific organ. Again, this area is advancing. In orthopedics, nerve blocks are frequently utilized in significant surgical procedures to inhibit abdominal cavity innervation. These blocks play a crucial role in achieving successful outcomes during the operations. They also perform hemilaminectomies using local anesthetic blocks. With local anesthetics, so pain control here involves interrupting the transmission of the nerve impulse and consequently achieving a quite good control of pain. We will explore dissociatives extensively, in addition to utilizing them as they offer valuable contributions to our medication options. Thoroughly today, yes, and in detail. And here our main dissociatives, yes, are ketamine, which again needs a license, but it is available in Russia. yes, or veterinary drugs analogous to ketamine, that is tyletamine, which is in fact the very active substance contained within Vezatil right there. The sole caveat with veterinary preparations is that the dissociatives are not administered in a pure form, but rather with the inclusion of, yes, all our veterinary drugs contain zolazepam along with benzodiazepines added for enhanced effect. Furthermore, as we will discuss shortly, there are only distinct benefits to this combination. There is nothing shameful about the fact that we use a mixture of these two drugs in veterinary medicine. Furthermore, in the treatment of pain, options include alpha-2 agonists, non-steroidal anti-inflammatory drugs, and non-narcotic central analgesics that can provide analgesia. Certainly, these drugs do provide effective pain relief once again. However, there are some nuances to consider. Yes, that is my perspective on the matter. That if veterinary anesthesiologists are here, you know them perfectly well. So again, for alpha-2 agonists, a large quantity of the actual drugs, high doses, are necessary in order to cause an analgesic effect. Well, NSAIDs have their own side effects in terms of affecting the gastrointestinal tract and affecting kidney function, meaning there are quite serious limitations for certain patient categories depending on the situation and the illnesses they have. Therefore, as you can see here, our choice is not very large if we do not have any license for the use of narcotic substances. When aiming to relax muscles effectively, we can consider increasing the usage of anesthetics, which plays a crucial role in our ideal anesthetic protocol for achieving optimal outcomes. That is, inhaled anesthetics. Combinations of anesthetics we can use, yes, meaning if we combine, for example, a dissociative with benzodiazepines, or if we use propofol along with dissociatives, we will once again achieve a satisfactory level of muscle relaxation. Separately, unfortunately, no single group of drugs except for muscle relaxants can provide such a good effect for muscle relaxation. And as possibly in addition to enhance the ideal anesthetic protocol involves emphasizing the importance of monitoring during the procedure. That is, our job as people performing anesthesia, yes, veterinary anesthesiologists, is always our primary responsibility is patient monitoring, ensuring we attentively observe their respiration, circulation, and overall homeostasis to maintain their well-being and health. In the absence of this essential element, the efficacy of the medications we provide, the validity of our licenses, and the quality of our equipment are all irrelevant. Our anesthetic management is simply destined for failure, yes, meaning without good quality monitoring, primarily clinical monitoring, yes. Furthermore, we rely once more on equipment for our needs, illustrating the significance it holds for us. Deep anesthesia for major, lengthy surgeries is impossible without the correct apparatus. And perhaps something that will scare you a bit, yes, what happens if anesthesiologists fail to conduct monitoring? Yes, these statistics originate from human medicine. Generally, the frequency of occurrence during the induction of anesthesia, meaning precisely when we introduce to the patient, yes, meaning some substance into the vein, roughly 0.75% chance, about 1 in 133 instances. Equipment failures contribute to roughly 14% of anesthetic mistakes. Yes, and 82%, as we already figured out, are still linked to the anesthesiologist's actions, or more precisely, due to their lack of presence, yes, and this grows significantly in the field of human medicine. The cost of treatment and hospital stay for these patients. Around you see the sum is $470 a day. Yes, considering the dollar rate, one can imagine what some rather serious sums, yes. So, once again, before my lecture, I urge you not to play with marbles, yes, not to sit on Facebook and VKontakte, and to be as attentive as possible to your patients and to definitely track all changes in their condition and make timely decisions. Yes, that is correctly. We have discussed the component of anesthetic management. I want to briefly remind you what is included in the stages of anesthesia, as this will help us understand which groups of drugs, at which stages, at what doses we can use them further. And I will remind you once again, we have premedication, which can have different functions and tasks. My absolute favorite premedication feature is sedation. When we administer certain sedative drugs, using sedatives for premedication greatly improves the effectiveness of any anesthesia, making procedures smoother by eliminating rough edges. Next, we perform induction, either immediately or after premedication, meaning we can also use several groups of drugs, it depends on our future intentions and objectives, for the whole operation time. After that, we enter the maintenance phase of anesthesia, which is when all drug concentrations have reached a plateau. And here our goal is to ensure maximum effect of muscle relaxation and analgesia, and the maximum level of sleep that suits us for this procedure. Following the completion of our procedure, the creature gradually begins to regain consciousness as a result of the medication we have given it. And at this point, it smoothly transitions into the post-operative phase, during which our primary task is to manage pain and restore physiological parameters to normal levels if they had dropped. For example, to raise the body temperature. For example, consequently, to correct the blood pressure if we had some hypotension during the anesthesia. We need to administer supplementary pain relief if that becomes necessary for us. Once more, we should apply the sedative medications if the animal is experiencing some delirium, agitation, or something else. It is believed that the greatest number of complications occur during the early post-operative phase, and therefore it requires from us, maximum attention is required here as from veterinary anesthesiologists, so as not to miss anything and not lose the patient. After putting in so much time and effort, we finally completed the operation with the skilled surgical team. Concerning sedation, I remind you that sedation refers to the patient's condition when they are fully conscious, but at the same time their primary senses are dulled and they are, let's say, sluggish. Their perception is also lowered here. This means they can still, to a certain extent, interact with the personnel, with the veterinarians and with the owners, but are mostly in a kind of sleepy state and allow manipulations to be performed on them that they normally would not permit. So this is the ideal world of sedation. Sedation is commonly used as the initial step in our anesthesia process before administering it, when the animal is getting ready for surgery. And I personally believe that the ideal sedation is hospital-based sedation. It is used quite frequently in human medicine. That is, if a person is to undergo surgery, it is advisable for them to choose a reputable anesthetic department for their hospitalization. They are given some calming tablets to take the night before, which consequently minimizes stress. Catecholamine release is influenced by a variety of medications used for anesthetic support, leading to their efficacy in practice. Requires smaller dosages for administration, and again the anesthesia goes smoothly, just as I mentioned previously. Recently in practice, for about the last 4 years in our hospital, we have been introducing, so to speak, the mandatory pre-hospital sedation of patients, specifically when they arrive for their pre-operative consultation. We recommend using specific drugs with the aim of reducing stress from visiting the clinic and from the animals staying without the owners in the hospital setting. In general, my recommendation is to opt for tablet versions of veterinary medications, as they are commonly the most effective option available on the market, lack any bitter taste, possibly even containing a delightful meaty flavor blooming into the palate, and animals consume them quite well. My preferred protocol, I will share with you a sort of insider tip for pre-hospital sedation, involves trazodone. There is the human drug triticum, meaning there are 150 milligrams in a tablet. It suits large or giant breed dogs. And there is also the veterinary express tranquilizer, which comes in 3 forms for small cats and dogs, and for medium and large breeds. It is very easy to dose, or you can follow the instructions so that, well, honestly, what the instructions say, 1 tablet per 4 kilograms, for example, for a cat or a dog, this amount of medication provides a sufficiently good effect, and there is no necessity to precisely calculate the milligrams of the active ingredient. Colleagues who are already familiar with these medications can certainly inform me that the express version of Uspocoin and Tritico are very strongly differentiated due to the fact that in express tranquilizers, succinate, trazodone, and specifically tritico hydrochloride. Actually, in everyday use, the difference between them isn't that great, so personally I prefer to consider again express Uspocoin when I use it. At a dosage of 3 to 5 milligrams per kilogram, that's enough to get an acceptable sedative effect. And at what interval, generally speaking, I suggest administering it. We usually prescribe it the night before surgery with a little food, and the morning of surgery an hour before leaving home. This period is insufficient for the medication to take effect, hence more time is needed. But because it was also given in the evening, it has had time to accumulate. What are the nuances here? Yes, you must always warn owners that individual reactions to sedatives are possible. This could be an overdose of sedation that wasn't anticipated, or conversely, we may be seeing a paradoxical effect come into play. So these occurrences are common in certain dogs and cats. My advice usually is to remain calm and not fret about it. If you gave the medication in the evening and saw such an unpleasant effect, then simply do not give it in the morning. We will figure out at the clinic exactly which medication or analog we can give your pet. Here is some other information which is, let's say, not very well verified, but it comes purely from practice. Some breeds, this is a Sheltie and a Collie, for some reason they often react incorrectly to trazodone and can exhibit this agitation. Yes, so whether this is related to the MDR1 mutation or not, it is not entirely known, because the dogs were very diverse, meaning some were tested for this mutation, some were not tested, and in general this effect manifested quite spontaneously. Therefore, careful consideration is advised when recommending this medication for this specific breed. It is important to note that my perspective is based on personal experience rather than published evidence. I have personally searched for it, but there is still no confirmation as of now. I also recommend incorporating trazodone into your regimen to enhance its benefits. When the animal comes into the clinic, if we see that it is still anxious, yes, for example, if a small Yorkie is trembling, we can also add gabapentin, additionally 20 milligrams per kilogram, which will result in a more pronounced sedative effect. However, we rarely observe any adverse effects of this nature. This approach is quite effective. The animals remain peaceful in the clinic, adapting well to the gentle treatment. Dogs are not panting. Yes, cats are not meowing. And again, we utilize this for the commencement of our anesthesia process as the preoperative medication. Afterwards, we will proceed to make essential modifications to the medication dosage to ensure accuracy in its future utilization. If it didn't help at all, meaning we see that the animal is behaving aggressively in the clinic, for example, you brought the owner, the cat in a carrier, brought her in, she resists any handling, then at this point we can turn to the assistance of injectable preparations. These are dissociatives, for example, Vezotil, 2 milligrams per 1 kilogram plus dexmedetomidine, 2 to 3 micrograms per 1 kilogram intramuscularly. They can be mixed. See? And overall we see a quite good sedative effect, allowing most manipulations such as catheter placement in principle. Catheterization can be performed using some lubricants mixed with anesthetics. Yes, and this will be sufficient for daily practice. That is, if you encountered an aggressive animal in the clinic, or if you didn't administer any drugs at all before coming to the clinic. We have finished with sedation, yes, meaning we have already given the sedation drugs, the patient feels well, or we didn't give anything at all, we don't need that. Next, we begin the induction stage, which is the process of administering step by step into anesthesia and achieving sufficient depth for performing the surgical operation. Here we offer several types of inductions: intravenous, inhalational, or intramuscular for your choice. Choose the most suitable one for you. We use intramuscular induction, well, let's say in extreme cases, if we cannot place a catheter, or if it is, for example, some exotic animal that will not tolerate any handling without prior sedation. So here we do not use this route of administration and induction routinely. Furthermore, we utilize an alternative method for induction known as inhalational induction. Despite its effectiveness, it is seen as somewhat inhumane due to the fear it induces in animals, especially cats. Dogs, when we use this induction method, and this typically does not result in a positive outcome, usually this means sick animals display symptoms like fever, difficulty breathing, and generally appearing unwell, shaking completely from fear. Moreover, dogs will never allow a mask to be placed on them, so this is certainly inhumane. We do not include animals that can be approached easily in our collection. Only highly aggressive ones that prevent close contact are featured here. Unfortunately, we have to manage this way. To handle cats that are actively attempting to attack, yes, meaning trying to strike, restraining them is practically impossible, so it happens very rarely, but in general we still have to resort to this method. Again, try to avoid it, that is, use the most pet-friendly approach possible, yes, and still endeavor to work on intravenous induction. If you are not doing that yet, yes, and as I already mentioned, yes, intravenous induction is the most ideal option. This involves inserting an IV catheter so that all essential procedures can be completed efficiently. Here, the drug dosage will be controlled very well. We know the metabolism, yes, meaning we can quickly administer. If things don't go as planned, an alternative is to initiate and maintain a steady infusion of medications. Use infusion therapy and provide fluid boluses as needed to support the patient. A multitude of advantages, so naturally this will be the preferred induction method in veterinary anesthesiology. And what should be utilized for induction? Indeed, in this case, there is also a subtle element of choice. It will depend on what you intend to do, yes, what concurrent health issues you are dealing with, yes, and whether you need intubation at all, maybe some short procedure, yes, and what type of surgery we will have. For inducing anesthesia, propofol is the most commonly used drug, encountered frequently in medical procedures. Like I mentioned before, this drug is commonly used in veterinary anesthesia. It is most effective when administered intravenously. Just a friendly reminder in case you are not familiar with using it. It is administered over the course of 1 minute, yes, a sort of slow bolus, yes, and it is used for hemodynamically stable patients, yes, and well, if you choose to avoid using additional drugs, you can opt for painless procedures such as an ultrasound examination, ensuring your comfort and well-being. If the animal does not allow this to be done, well, without any other thing, support is provided through medication by utilizing dissociative anesthetics, specifically tiotamine zolazepam. When using propofol, apnea is a common occurrence. Be prepared by keeping intubation equipment and a laryngoscope nearby, and do not be afraid of it. Being proactive is key to managing this side effect effectively. It is reversible effect, so consequently simply be prepared ahead of time and expect this particular outcome. For patients who are hemodynamically unstable, we can consider using monotherapy. More details on this will be provided later on. However, most frequently we combine dissociative anesthetics with propofol, primarily because, regrettably, at low doses of dissociative anesthetics, intubation is impossible, so we often resort to this technique because spontaneous breathing, to maintain without protection, can prove to be quite challenging. Gas is not administered prior to surgery for most cases, but it is reserved for aggressive or exotic animals such as rabbits, chinchillas, and guinea pigs, as I mentioned before. Ferrets, because again, due to their mobility and small size, they might not allow anything to be done before you administer these. sedative drugs. So in principle, it has probably become a tradition, yes, to use inhalational anesthetics for induction in exotics, and everyone has learned to work with this and generally knows what subtleties need to be considered when administering this category of medications to exotic animals. And we also have the option used for induction, which is ketamine plus a benzodiazepine, or opioids plus a benzodiazepine. So here again we have our favorite nuance, that a license is needed for the drugs for using this group of drugs. Yes, meaning not all clinics have one. Once again, the focus is on propofol and dissociative anesthetics as key components in medical procedures. When it comes to dissociative anesthetics, our current primary option is to use them frequently, as previously stated. This remains our sole choice for now. Medications using tiltamine and zolazepam for anesthetic purposes. Let me remind you the general information about these substances. Tiltamine is a dissociative anesthetic which causes analgesia and sufficiently deep sedation, and zolazepam is a benzodiazepine which consequently causes central nervous system depression, possesses anticonvulsant properties, and can function as a muscle relaxant. At this very moment within the Russian Federation, these represent the sole chemical compounds available for our utilization in routine clinical practice, and they are invariably presented together in this specific manner. So, the manufacturer doesn't separate them at all, because tiletamine has quite serious side effects when seizures are treated with this as the sole therapy. Basically, yes, and the so-called catalepsy. That's why they always add a benzodiazepine here, zolazepam, which specifically neutralizes these effects. And I'll briefly, yes, talk about the pharmacology of tiltamine, which is an NMDA receptor antagonist, and it is stronger. A research has shown that the ketamine's effectiveness is quadrupled from its original dose. And 4 times, this is according to modest estimates. There is one study where the effectiveness in mice and rats was compared, and they found that ketamines and tiltamines can in principle be even 10 times stronger in terms of its properties. And here it has the advantages, yes, compared to ketamine. Again, it has some further effects upon memory. Yes, for example, there are precise studies on humans, and possibly in the near future there may be new medications in human medicine that incorporate tiltamine as an ingredient to enhance their therapeutic effects. Like I mentioned before, tiltamine enters cats more rapidly than in monomode, as there is a distinct nuance to its usage. When it is present in the drug in combination with zolazepam, well, zolazepam acts for up to 4 hours in them. So cats have this specific sedative effect and less pronounced agitation compared to dogs. In dogs, conversely, zolazepam is metabolized forward, and that's why they are more agitated after that. We administer this group of drugs. In terms of metabolism, tiltamine is processed by the liver and then excreted by the kidneys. Therefore, the dosage of these medications needs to be adjusted accordingly. Patients suffering from renal failure or hepatic failure, yes, are in need of immediate medical attention. So, and we use it, as I mentioned, for sedation and analgesia. And here are the side effects that we have, which are specifically caused by the pharmacological properties inherent to tiltamine. These are an increase in heart rate and a rise in blood pressure suggests elevation in heart rate and arterial pressure. This is due to the fact that they increase the tone of the sympathetic system, specifically this group of drugs, dissociative anesthetics, you see. At the same time, this catecholamine appears, and the catecholamine then acts directly upon the system, the cardiac muscle, thereby increasing the heart rate and blood pressure. It's an interesting effect that tiltamine, like ketamine, can unfortunately have a paradoxical effect. In animals, in humans, if there is already adrenal insufficiency, yes, this applies to animals in sepsis, animals already in a severe state, in shock. So when the adrenal glands' resources are exhausted, meaning catecholamine is no longer produced in large quantities, you see, on the flip side,
Dissociative anesthetics have the ability to reduce blood pressure and slow down heart rate, which is a well-documented phenomenon in the field of human medicine. And in veterinary practice, therefore, this specific detail must always be accounted for when administering any class of these medications, and adjustments must be made precisely in the initial stages. As for zolazepam, as I already mentioned, it is a benzodiazepine, yes, meaning its pharmacological group interacts with GABA receptors, which is a different group of receptors. It does not have an analgesic effect that is handled by tyletamine. It causes muscle relaxation and also has an anticonvulsant effect. It does not affect hemodynamics at all, which is why benzodiazepines can be used considered safe in animals in any condition, yes, and with heart and blood vessel system diseases, including that. The adverse reactions that are associated with the administration of benzodiazepines and medications that include them are apnea, hypotonia, and liver damage, which occurs precisely with serious overdoses or with excessively prolonged administration. Routine use does not cause any liver damage. That is, does not happen when using these drugs. Feel safe, there is no need to fear in this place. To summarize, yes, concerning the pharmacological application of these specific drugs, we can utilize them. Thiletamine, zolazepam, and their combination used as the primary anesthetic agent within a comprehensive anesthesia protocol for performing surgical procedures. During clinical procedures, yes, if we need some sedation or immobilization, and for inducing the animal into a state of light anesthesia, prior to the administration of inhalation anesthesia, specifically for the purpose of intubation or applying a mask, should that become necessary. This particular group of medications is perfectly suited for that purpose. What we had before 2023, yes, on the veterinary drug market in Russia, this was Zolotil, a drug that we are all familiar with, which has been on the market for quite some time now. And then his generic phthalazole appeared, that is from the company. Yes, if Zolotil is produced by Verbac, then phthalazole must be their creation as well. Zoetis, they were positioned close to one another in a way that made them very alike. Yes, indeed. Complete analogs you could, well, I mean, if there were managers, yes, any. In terms of sales, it was recommended to substitute Zolotil with phthalazole, as they asserted that these two medications were completely indistinguishable. However, in actuality, there is a slight distinction between them, although it is incredibly minor and will only be detectable if you use them regularly. Them in practice, yes, these drugs. Some colleagues have noted that phthalazole has, let's say, a less pronounced sedative effect, a less pronounced analgesic effect. Again, this info is not written anywhere. They confirmed that these are simply the subjective thoughts of co-workers who have experienced the effects of this medication. Overall, they are very similar composition, 250 milligrams of tyletamine and 250 milligrams of zolazepam in each vial. Zolotil should be administered either intravenously or intramuscularly following the instructions provided. Phthalazole is only described for intramuscular injection. We use it off-label intravenously and intraperitoneally. Well, in the general, we have not seen any additional side effects associated with this. And so the solvent that was included along with the Zolotil package right there, there is a clear message on the slide stating that phthalazole cannot be used as a solvent in this case. This was the situation we faced up until the year 2023, yes, and the specific nuance connected with them in everyday practice was their overall expense, meaning it was rather expensive medications and the price frequently fluctuated based on the dollar and euro exchange rates. Moreover, there were instances, yes, I recall those moments with a genuine sense of dread now. The items were absent from the shelves because of a supply crisis, leading to significant problems. We were uncertain about the next steps and how to address the situation. These drugs were bought for any price, yes, and this was a very big problem for all of veterinary medicine, probably because practice is impossible without these drugs, meaning no surgery could be done. Yes, that is, well, I'm just exaggerating, but most procedures can't be done, yes, meaning there are no analgesics at all. We found ourselves having to balance a wide range of medications and methodologies, so to speak, extensively.
Yes, and for routine practice, such juggling is not very comfortable, having to devise something new daily, and I believe you will concur with me. Yes? Therefore, I am genuinely very pleased that since this year we have an alternative medication whose properties, it is essentially the equivalent of tiletamine known as phthalazole and zoletil. This medication is Vezotil, correct? As I said, the active ingredients are tiletamine and zolazepam hydrochloride. It's a lyophilized product, same as before. Like zoletil and telazole, solvent included, same absolute makeup, 250 milligrams of tiletamine and zolazepam in one vial. As a result, in terms of how it is commercialized, it remains unchanged in essence and presentation. The benefit of this product is that it is manufactured locally at the Moscow Endocrine Plant, a facility known for producing a wide variety of medications and supplements, and this includes narcotic and psychotropic substances. So it serves as the distributor for these medications to all hospitals in Russia, at least within our central region. Therefore, the quality control there is maintained at a very high level, and I do not anticipate any discrepancies compared to in France, zoletil production or the manufacturing of phthalazole is carried out. I honestly have not even investigated its country of origin. There are advantages here, so there shouldn't be any supply interruptions. That is, again, all these substances from which it is made are always available, and well, the rate, the dollar and euro should not influence here, or only minimally, so we must always maintain a competitive price here. What are the differences or similarities, for example, in the representative of this group of zoletil preparations? And how do they differ from Vezotil? We have the same 250 milligrams of tiletamine and 250 milligrams of zolazepam here. The same thing in Vezotil, as I already mentioned. Vezotil is the same as zoletil, suitable for both intravenous and intramuscular administration. Here's the difference here. We have sugar present both here and there, yes, so to speak. Lactose sugar is included in the formulation of this medication known as zoletil, while maltose sugar is found in another similar drug called Vezotil. Here's the nuance. Maltose in the bodies of animals and humans transforms into... Yes, here I am switching this slide. Maltose undergoes a conversion into two glucose molecules, providing an additional energy source. Thus, one glucose molecule is derived in the process. Lactose, when administered intravenously or intramuscularly, is hardly metabolized at all. That is, it breaks down into a molecule of glucose and a molecule of galactose. So, accordingly, the galactose molecule is not excreted exactly. More precisely, on the contrary, they are excreted by the kidneys, yes, here, but at the same time, they have this kind of indivisible structure and additionally burden the nephron kidney. And as for the glucose molecules, which they can serve as an energy source and assist in transportation, making them versatile substances for various purposes, with certain ions in the renal medulla leading to changes in function. Well, kind of, on the contrary, it has such a... In providing assistance, there is indeed a small but noticeably positive physiological impact present, indicating the effectiveness despite the minimal quantity. At the molecular level, probably at the cellular level. Here, considering this formula, yes, the difference in sugars, there might in principle be some additional advantage. Regrettably, research on kidney-related issues has been lacking in duration, yet I believe that this problem requires further investigation over an extended period. In the future, such research will emerge, and we will be able to share some information with you. On this topic, perhaps we will even have some advantage in our country compared to others. An additional advantage compared to foreign counterparts. Regarding the official dosages of Vezotil, yes, if you look here, they might scare you a little. I mean, In practice, we don't often use such dosages, yes, because these dosages are used, as mentioned here, for
Monomode cables are safe despite their large size, providing a cumulative dose quickly when needed. This is important because they ensure reliable and secure data transmission even in challenging environments.
You can rest assured about the development of side effects. I am here.
I can certainly say it out loud because I know that in the hall it's probably not very visible. Yes, here we recommend 7 to 10 milligrams per kilogram for the clinical examination of dogs here. The IV dosage now decreases to 5 milligrams per kilogram. For minor surgical procedures requiring a brief episode of general anesthesia, a maximum dosage of up to 15 milligrams can be administered with consideration for additional boluses if necessary. Repeated administrations of this dosage intravenously can help you achieve the desired amount once again. A dose of less than 7.5 milligrams.
Well, if it's a prolonged general anesthesia for extensive procedures, then up to 25 milligrams is allowed, apparently. Intramuscular injections, intravenously here we will have 10 milligrams per kilogram. So again, these are some repeating boluses. If you suddenly need to perform during the operation, it can be reiterated as many times as needed without causing any significant adverse effects on its progress. For cats, the doses are smaller here. Intramuscularly up to 10 milligrams per kilogram, intravenously 5 milligrams per kilogram. And if it's some kind of prolonged anesthesia, then it's 15 milligrams intramuscularly or 7.5 intravenously milligrams. Well, as I mentioned before, you can reuse it in a dose of, say, 1/3 or 1/2 of the initial dose. That is, our patients have demonstrated excellent tolerance to it.
When combined with other anesthetics and administered intravenously, a dosage of 0.5 to 2 milligrams per kilogram of Vesotil is utilized for induction, along with analgesics.
I mean intravenously, yes, that is administration, but if it's maintenance, then you can use 1 to 2 milligrams per kilogram per hour.
If there is a painful episode, yes, meaning you understand that the analgesia is insufficient, we can temporarily increase the rate, yes, meaning here even up to 6 milligrams per kilogram per hour.
The dosage can reach that level, but honestly, in my practice, I've rarely used such large doses. Is this enough for pain relief? Comparing taltamine to ketamine, we can roughly calculate and then compare the total milligrams of Vesotil against the milligrams of tiltamine that various sources suggest are necessary to achieve the correct level of analgesia. Here they are equivalent. We have 8 milligrams of Vesotil, which is the same as 4 milligrams per kilogram of ketamine. It is intriguing that every source we refer to in the field of anesthesiology, specifically modern anesthesiology textbooks, has a consistent perspective. A fairly wide range of ketamine doses is given. Certain sources cite a potential maximum of 6 milligrams per dose. Kilogram of ketamine, so the therapeutic range here, it's quite high and you don't need to hold back here. There won't be any particularly pronounced side effects other than prolonged sedation even with these high doses of Vesotil. When talking about monotherapy, we have 3 levels here.
Pain, that is moderate pain, severe pain, and intense pain. When discussing moderate pain, skin neoplasms and the insertion of pleural drains are relevant examples that come to mind. These procedures can be associated with discomfort, for example, or some primary surgical wound debridements. 1 to 2 milligrams per kilogram per hour will be sufficient here, and we always start these procedures with a water bolus. Alternatively, if this skin growth is minimal, meaning it is small, we comprehend. If this intervention will last 10 to 15 to 20 minutes, then you can practically manage with just a water bolus of this medication. And then, using some maintenance drugs like propofol or gas, we can carry out our entire brief procedure. Local methods can complement drug therapy to enhance treatment effectiveness. If this is already an intervention associated with pronounced pain, such as abdominal surgeries,
In cases where emergency hysterectomy or simple osteosynthesis procedures like wrist bone fixation are needed, these situations can arise. Or urethrostomy, we can use 2 to 4 milligrams per kilogram per hour with an initial bolus of about 1.5 to 2 milligrams. So we will move on to drug combinations with you a little later, but in my opinion, a dosage of 2 milligrams per kilogram per hour as an infusion rate will be sufficient for these interventions. By utilizing alternative local methods, you can further reduce the amount of medications required, offering potential health benefits. And generally speaking, even significantly less infusion at a constant rate may be required here. If the bolus is substantial, procedures such as syntheses and spinal surgeries like hemilaminectomies may be required. Thoracoscopy. Surgical procedures such as liver resection and limb amputation require very high doses of medication, typically administered in monomode. No medication can be used alone. Even when we use opioids, we will still complement them with something else. Potential side effects may arise. Therefore, it is recommended to administer approximately 2.5 to 3 milligrams per kilogram as a bolus dose. Enough. That is, again, you can put here IPS reaches 4 to 5 milligrams per kilogram per hour sometimes, but I usually stick to 2. 3 milligrams per kilogram per hour max of tiltamine and zolazepam. And I supplement with something else additionally, that is again to minimize the development of side effects. About combinations, that is, I promise to tell you, probably this is my protocol for every day. We still conduct induction with propofol if these are stable animals. Only for intubation, that is 8 to 10 milligrams per kilogram until effect, and then we proceed with intubation. Otherwise, if we are not using any local techniques here, you must always apply the Vesotil bolus. Here, 1 to 2 milligrams per kilogram slowly. You can dilute it as convenient for you, for example, for a cat or a dog in 5 to 10 milliliters. Saline solution or ionosterol, and somewhere there, shaving, washing, making this bolus. That is, in my opinion, such a combination is less likely to cause apnea, and most likely you will even enter the operating room with spontaneous breathing. It is clear that intubation is necessary here because you are obviously preparing for some kind of medium or major intervention. In the operating room, we usually set up an infusion at a constant rate of about, well, you can start at 0.25 milligrams per kilogram if you don't anticipate any significant level of pain. If you already anticipate that there will be some moderate or significant level of pain, then we accordingly start with 1 to 2 milligrams per kilogram per hour. You have the option to include lidocaine here or stick with monomode if you have no intention of changing. Again, no extensive intervention whatsoever. One reason I prefer lidocaine is its ability to be utilized during the post-operative phase, ensuring ongoing effectiveness. It is quite good, such an analgesic that does not cause a pronounced reaction, marked sedation or side effects, and in fact, it is still possible to use it effectively for pain management following surgery. There are also other schemes, that is, the bolus, again, the same Vesotil, and then we continue the IPS at the same dosages, and we can add dexmedetomidine. Dose starts at 0.125 mcg per kilos per hour. The maximum dose is 1.5 micrograms per kilogram per hour. I'll be honest with you that I probably always end up at 0.5 microgram per kilogram per hour. Again, because the multimodal approach is designed for this so as not to maintain appropriate levels of medication to avoid surpassing dosages and causing unnecessary side effects. In my view, this is crucial for most treatments. That should be sufficient. And then there is this one, which is quite a mixed bag, specifically the Vesotil bolus. For more extensive surgical interventions, we are adding IPS Vesotil, lidocaine, and dexmedetomidine right here. This approach can effectively support a unilateral mastectomy procedure, for instance. It can work well for mini hemilaminectomy in orthopedics in principle, Most orthopedic surgeries can be performed using this scheme if you are not familiar with local techniques. The only thing is that the dosages will be quite high and there will be a prolonged recovery from anesthesia. It's evident that we must adequately prepare and ensure thorough quality monitoring procedures to deal with this situation effectively in a normal manner. And for sleep, if we are to consider all protocols within our anesthesiological triad, we use isoflurane here. If such an option is available, or propofol in an infusion at a constant rate. Usually 5 to 10 milligrams per kilogram per hour is enough. That is, if the patient is not asleep. In some cases, it can be increased to 12 milligrams per kilogram per hour. This is permissible but rarely encountered, to be honest, specifically in a multimodal scheme. It is possible that these are just a few young creatures with adaptable minds that were not administered any premedication. Usually 6 milligrams per kilogram per hour is enough. Regarding animals with unstable hemodynamics, that is, if you have to work with critical cases, patient. Again, the opinion always arises here that we should treat such patients only with opioids, that is, using ketamine, benzodiazepines, because they provide precisely such a profile of hemodynamic stability. But since in practice, unfortunately, we are sometimes deprived of the opportunity to use these remarkable medications, and in our everyday practice, this occurs even more frequently, then we can use other groups of medications with you. In my opinion, the ideal application here would be precisely dissociatives, and Vesotil is perfectly suited here. Moreover, in this case, when I work with an unstable patient in shock with sepsis and so on, I use Vesotil specifically as the first agent for induction. Therefore, the recommended bolus is between 1 to 2 milligrams per kilogram, followed by titrating propofol carefully to achieve the desired effect. To perform intubation. In this case, it might be 4 milligrams per kilogram. I call this protocol jokingly Vesofol due to an existing analog. In the field of human medicine, doctors refer to it as ketofol, a term commonly used. In the field of intensive care, anesthesiologists frequently care for critically ill patients and follow established protocols. There is a significant body of research supporting their methods and practices. The use of a combination of ketamine and propofol has been shown to result in optimal hemodynamic stability, ensuring the best possible outcomes for patients undergoing treatment. In my experience, I can confidently confirm that using tyltamine, zolazepam, and propofol together maintains a consistent hemodynamic stability profile. If this can even be called stability, because these patients continue to be unstable despite the fact that we administer these medications to them. For maintenance, I use tiny doses of painkillers, usually up to 2 milligrams per hour per kilo. I probably always stay at 0.5 because these patients, due to their condition, don't really require large doses of analgesics, not because they don't feel pain, but because the metabolism of these drugs is altered in them. Therefore, we require reduced quantities to produce equivalent results as observed in animals that are in good health. And here, the combination most often used was dicaine. Dexmedetomidine can technically be added to this regimen, but in a very small dosage considering the patient's underlying issue. In case he continues to experience any form of heart failure or diminished myocardial function, it is better to refuse the expressed dexmedetomidine, and lidocaine is also used with caution, so everything here is, you could say, in terms of effect, in terms of taste. Maintenance is often isoflurane, sevoflurane, or very small doses of propofol if you don't have access to these drugs. And of course, for all patients with unstable hemodynamics, we must have norepinephrine or dopamine ready. That is, it's a common practice. There was an intriguing case that caught my attention. I was also preparing a report on sepsis and anesthesia during sepsis and watched quite a large number of videos on YouTube, which are specifically dedicated to medical practice, including the Burdenko hospitals and so on. And there was a very interesting video where there was a hall similar to ours, and accordingly the doctor was explaining exactly which protocols he uses. patients with unstable hemodynamics, and he asked the audience what protocol they use, what they generally use for induction. And for me, it was probably such a shock to hear from humane medicine doctors they use norepinephrine right away for premedication. So how, well, it's like not an analgesic, that is, not a sedative, that is, they probably have such a... Their anesthesiology approach centers around norepinephrine due to their understanding that it is crucial to their triad. After the administration of even a single milligram of ketamine, it is probable that the patient will experience a significant drop in blood pressure. Therefore, they always start their protocol, apparently these people, with the use of norepinephrine, that is, they apply it first. Sedation medications or analgesia, and as I already mentioned, we have two drugs present here, norepinephrine or dopamine. What's the difference? That is, if someone does not know what the essential criterion is for making the decision about which medication we will utilize for the patient or not. In the patient, there may be a predominance of vasodilation or a decrease in myocardial function or the presence of bradycardia. Each scenario requires careful consideration for appropriate management. It appeared during induction. That is, if it is vasodilation, then we use norepinephrine as the first choice drug. If it is a decrease in myocardial function or bradycardia, we use dopamine, meaning we see hypotension with bradycardia, we use dopamine. That is, for me, at the very least, this drug will be the first choice in this situation. They can be combined if we do not achieve a certain effect of hemodynamic stability, meaning this is also allowed, though there are nuances. But as such, it is suitable for mandatory use as a protocol. As for the animals with liver and kidney diseases, that is, Vasotil, as I already mentioned, has most likely the profile is more conducive to kidney diseases, meaning it should theoretically injure them less specifically and reduce kidney function. But we still need to reduce the dose of all components of the aid by 25 to 50% except for isoflurane, because it does not affect the kidneys in any way. And with these animals, one must always expect a prolonged reversal, as they are unable to properly process these drugs, meaning their metabolism, their excretion is likely reduced, so it is essential we must be cautious when adjusting the dosage. Avoiding very small doses does not imply that we should begin with excessively large amounts. Vasotil at 0.1 milligrams per kilogram total, or something. We just need to be reasonable here, and not to start the infusion at a constant rate, so to speak, at full throttle. Well, and probably the most important nuance with these patients is when you encounter this group of patients, that they must remain in their homeostasis in which they are accustomed to staying, meaning they should not have any bradycardia, nor should they have any tachycardia. They should not have hypotension, they should not have hypertension, they should have a normal temperature and preferably breathe spontaneously. In other words, if you are approaching these parameters, then most likely success awaits you. If you have completely given up and are not monitoring the pressure, temperature, or anything else, then most likely you will encounter complications in the post-separation period related to the deterioration of kidney or liver function. If your patient suffered from this beforehand, I will share a brief clinical case involving the use of Vasotil, a small but important example. Meet Timosha, the dog facing a grave issue. MRI reveals atlantoaxial instability, posing a serious problem for this furry friend. Of course, symptoms develop before this, such as the forced position of the head, ataxia, and decreased appetite. They came to the clinic with these complaints, and after a neurological examination, an MRI was ordered, and they diagnosed atlantoaxial instability. At the same time, the incoming tests, namely the biochemical complete blood count, ECHCG and ECG, showed no abnormalities. So there were some changes, of course, since he is a 3-year-old Yorkshire Terrier, but they were generally insignificant for the anesthesia. Here is a photo after the surgery, as you can see. Which protocol did I adhere to, since there was a lack of access to medication in this scenario, forcing us to make do with what resources we currently possess in our arsenal? He was constantly taking gabapentin. since he had neurogenic pain associated with the illness, and they gave him trazodone for pre-meds because he was quite distressed. He absolutely refused to get in touch, therefore we required some assistance. Sedation is now in the clinic. Therefore, my selection was a careful approach, administering 1 milligram per kilogram as an intravenous bolus of Vezotil. And then there was a small infusion at a constant rate of 1 milligram per kilogram. More lidocaine. I opted against using dexmedetomidine in this case to avoid potential risks of bradycardia and elevated blood pressure, thereby choosing an alternative. Not to complicate life for the surgeon and himself, and not to complicate Tosh's life, and not to provoke. Initially, the original intention was to administer very small doses of these drugs to observe their effects on the brain. If any issues arose, we planned to address them using boluses. About 15 minutes into the procedure, Tosha started experiencing pain when the surgeon began vertebrae manipulation, so a 2 milligram per kilogram Vezotil bolus was needed, and we had to be cautious. Adding more dexmedetomidine increased Vezotil to 2 milligrams per kilogram. At the same time, the patient was hemodynamically stable, and he didn't have any significant tachycardia after the bolus, which is a very good nuance here, because that tachycardia can also be detrimental for such patients. 30 minutes after the operation began, specifically after we administered dexmedetomidine, I decided to discontinue it because throughout the entire operation there were absolutely no indication of pain that was not under control. All our physiological indicators were within the normal range or thereabouts, and I decided to sort of cancel it. Then, already at some final stages, I observed a lowering of the heart rate and a rise in arterial pressure, yet even the boluses offered no further assistance, and in order to avoid any potential brain swelling that may arise during the course of this procedure, I gave prophylactic mannitol 0.5 grams per kilo. Colleagues might judge me, but then from my clinical perspective, it seemed to me that it would be better to let him do it rather than me, because something strange started happening. Well, I'll show you a little video. This patch, for those who haven't encountered it, is quite an essential item in such operations, because if the animal is petite, head surgery leaves little time for delicate adjustments. Exactness counts the most for success in small creatures. Even the smallest change in the shape can cause a significant variation in the outcome. The head of such a small patient or the interchial tube, and accordingly, it can ruin the entire operation process. Well, as you may have seen, perhaps, on the monitor, meaning his heart rate was quite steady, around 100 to 110 overall. Well, that is, the level was the one that was achieved under some normotension. His exhaled CO2 was also normal, 41. The saturation here on the video is low simply because the sensor was coming loose. Off the screen, the pulse oximeter, you see, and there was no opportunity to adjust it, meaning in such situations sometimes it's better not to breathe, because again, you can ruin the entire condition of the patient just because you are there, as if you are interfering in the process. So Toshka here after surgery, the first video starts, that's 45 minutes post-op, this is 15 minutes. So the dexmedetomidine had already been discontinued, the Vezotil was in the IPS, and we also had lidocaine. We then continued the Vezotil infusion at 0.25 milligrams per kilogram per hour as we waited. Some kind of quite intense pain syndrome. And they also continued the infusion at a constant rate. Well, and after that he began to behave very restlessly. We had to add dexmedetomidine for sedation. Well, this is how he looked about 45 minutes later. So you see, he's already responding to all stimuli, and I'm whistling songs to him. Overall, he's kind of already ready to communicate with the staff. This was after 10-15 minutes after exiting, you're aware,
the operating room. And here he is also, as you can see, already breathing spontaneously, meaning he has been extubated.
and once again he is showing some signs of life.
To summarize everything, let's discuss how we can apply Vesatil across the different phases of anesthesia. Specifically during pre-medication, we have the option to utilize it for achieving sedation. Administer up to 3 milligrams per kilogram as a bolus for induction, or consider intramuscular injection if required for the procedure. We can utilize it for maintaining anesthesia through a continuous infusion technique.
Upon coming out of anesthesia, it's clear that ideally you should turn it off if you don't plan to use it as an analgesic. You see,
During the initial recovery period, administer a maximum dosage of 0.5 milligrams per kilogram for pain management.
in general there is no notable sedation seen at these doses, and it continues to provide pain relief even at high dosage levels without causing sedative effects. When we use it in an infusion at a constant rate, for example in combination with lidocaine. Well, and the clinical studies, yes, I'll tell you a little about them. How all of this happened.
So, do you have the information on the volume of those clinical trials? 6 clinics participated here in 2023. VetLife, Biocontrol, VetProfalliance, Four Paws, and Kindtail, and the Pantera Vet Clinic.
350 animals participated here, that is, cats and dogs of various ages and breeds. Specific criteria were established for the animals participating in the study. They had to be healthy, young, and devoid of any serious underlying health conditions that could specifically respond to the use of dissociative anesthetics. Here we assessed the condition of the animals during the preoperative, intraoperative, and postoperative periods.
Up to 24 hours of observation were conducted on these animals, and they assessed everything based on the risk of mass,
and generally underwent all the necessary examinations for anesthesia, that is, a biochemical blood test, a complete blood count, and an ECG.
An echocardiogram, yes, and if necessary, an X-ray or an ultrasound.
Here we studied the intravenous intramuscular method of administration and infusion at a constant rate. The dosage here was individualized, meaning it depended on what exactly we used and what specific operation we conducted, and so the result we achieved was obtaining.
Each person's application form has been filled out, indicating that the drug has successfully finished the clinical trials.
What the researchers noted, yes, meaning doctors like myself, and I in fact myself, that we had very good tolerance of this medication, you see.
It is in fact a reliable method for administering anesthesia to both cats and dogs, ensuring their safety during procedures.
We did not notice any specific negative differences during the study of this drug, yes.
That is, unlike the analogs Zolatil and Phthalazole.
There were no observed reductions in effectiveness or appearance of new side effects during the study. Here,
there were even some advantages, meaning that cats showed a reduction in drooling during the postoperative period, yes, which is something they all actually suffer from.
Well, and there was probably a slightly more pronounced sedative effect, so we didn't see exactly this kind of agitated state can be induced by using Zolatil or Phthalazole alone, causing distress and excitement. What else can I say? Yes, that is, certain researchers have observed that Vesatil exhibits a more distinct impact in this particular context. Yes, the sedation level is slightly higher than its counterparts, you see, and this helped to reduce the dosages of propofol and achieve intubation at lower doses of the remaining drugs. Also, when analgesia was used as a rescuer, specifically in the form of boluses during surgery, less pronounced tachycardia was also noted.
Yes, which is characteristic of its application.
Of ketamine and dissociatives, or its complete absence. So they also noted a decrease in hypersalivation. I already mentioned this, yes, in dogs and cats. Well, and there's also such an opinion.
In comparison to similar products, Vesatil demonstrates increased stability, especially when employed in a continuous infusion setup where it is diluted and left running for extended periods of time.
That is, its effectiveness in this diluted form with various solutions does not decrease. That's all from me. Thank you for your attention. If there are any questions, I would be very happy to answer them.
Yes, Stepan Stepanovich, thank you for a very interesting lecture. You helped us learn a lot of interesting things about providing quality anesthesiology assistance, and among other things, understand the differences and applications of the drug with the N-tylaltamine compared to ketamine. They discussed numerous advantages of utilizing Vesotil, highlighting its positive aspects. I would like to start with questions from our live audience. Thank you very much to them for finding the time to visit us. Perhaps someone has questions.
Hello, my name is Evgenia from the Esculap Veterinary Clinic. First and foremost, I want to thank you for the excellent lecture. The questions I had prepared in advance, you have already answered. This is a study of the drug specifically on the territory of Russia. And I was particularly interested in the question of animals waking up. How long, what is the duration of waking up? Are there any perhaps unique characteristics, unlike other medications we are more familiar with? Well, then I'll limit myself to the question I would like to know about lactating animals, pregnant animals. How are they doing?
Look, regarding lactating and pregnant women, I'll explain right away. The drug accordingly penetrates the placental barrier. Like its counterparts, therefore its use in pregnant and lactating animals should be with caution. If performing a cesarean section, based on contemporary protocols, we are obliged to complete the task. On epidural anesthesia, which is the preferred method where we see better survival rates of the offspring and stability of the pregnant animal. Tylaltamine combined with zolazepam should only be given following the appropriate test results being obtained prior to administration. This is suggested by all the guides that we need to explore together. After you have extracted the fruits, use in pregnant animals is possible and necessary. If you notice any pain or insufficient depth of anesthesia, you cannot achieve it with other medications. Or synchronization with the ventilator. By the way, such situations also occur. If we are working with certain specific breeds, for example, a brachycephalic, sometimes gray hairs appear when the animal cannot breathe properly. That is, it is difficult to synchronize it because here every drop of systemic drugs counts, and you wait until the surgeon simply retrieves the fruits for themselves. You maneuver somehow with the help of medications, juggle, and then apply them. The medication that effectively helps synchronize the animal with mechanical ventilation, because once again the chest simply has its nuances and during spontaneous breathing they cannot breathe normally. That is, the use in pregnant women, as I already mentioned, is possible after the extraction of the fetuses. Regarding lactation, again, because it can cross both the placental barrier and be eliminated through breastfeeding, it is passed on to the baby. Feeding is still undesirable in the first few hours after administering the medication, but the metabolism is sufficient. Quickly, so this moment when we revive the puppies after a cesarean section, that is, bring them to consciousness, and they are already capable of displaying a sucking reflex, though somewhat limited in nature. Practically after applying small doses of Vesotil. We are not seeing any clinical side effects in the puppies. They are not becoming less sedated, nor are they refusing to food. The usage of isn't prohibited, but it should be carefully adjusted in small increments to ensure safety, with doses requiring cautious titration, solely for pain relief in emergency situations. That is, for some routine interventions. Scheduled, I would still not choose this group of drugs as the main one. Regarding waking up, how animals come out of anesthesia after using Vesotil, I wouldn't say that differs in a negative way, causing an increase in the amount of time required. On the contrary, even Toshka was one of the few patients, the first one we tried, and the operation was quite serious. But at the same time, he literally, I showed the video for about 15 minutes, he was already showing some signs of life,
After 30 to 40 minutes, he was already lifting his head, and after about an hour, he was moving around the cage. This is roughly equivalent to the counterparts, and for cats, the same effect. So I would say that within an hour, we are already reaching some kind of, with awareness, a natural posture, they are already beginning to have the ability to move. Again, there are many very individual characteristics specific to the animals themselves. That is, we both understand perfectly well that you can take 5 cats, give them the same dosage, and one will sleep longer than the other because they are cats. Here, we always have one argument, that they are unique animals. And I must say, it feels much gentler. It works in a way. I don't know, maybe it's a particular feature of the formula. But their agitation and drooling are significantly less pronounced in the post-operative period. That is my opinion and my feelings from using the medication. Thank you.
Let's move on to the online audience. Perhaps during this time, the offline audience will have some more questions. Question from Sergei Solkov. Stepan Stepanovich, in the Vesotil instructions, after mixing the solution, about storage time and the use of the medication. Question mark.
What instructions?
What is
Which
it
one?
like after preparing the solution?
Do you mean inside the bottle itself?
Yes. Judging by the question, yes. Here,
Yes.
if I may.
Maybe yes, let's do it.
I will answer this question together
Yes,
with
maybe
you.
I'll turn on the slide now.
We had there.
The thing is, we are actually the company VetStem. We are residents of Skolkovo. By the way, I would like to note that we are also broadcasting today's stream from the Technopark.
What? Yes, I've turned on the slide here.
Here we have...
With a brief introduction,
Yes,
this
yes, yes.
text contains 39 characters. We are extremely dedicated to ensuring the high quality of our newly developed pharmaceutical product. But we have studied all its characteristics and properties in great detail. Not just specifically Vesotil, but in principle all drugs with the active ingredient tyltamine zolazepam. In connection with this, we, let's say, noted unique properties of these medications. That is, we recommend all veterinarians to mandatorily store ready-made solutions only in the refrigerator when using them, and dissolve in principle the active substances in a larger volume of solvent. Thus, the active substances, in particular, zolazepam, experience reduced hydrolysis rates.
Yes. So here we have, as you can see, even on the slide, it is recommended that the shelf life of the diluted preparation is up to 10 days.
But honestly, I haven't noticed any decrease in effectiveness after this storage period expires. When stored in the refrigerator in a dark, cool place, did not notice.
And this is due to the fact that in studies, that is, laboratory ones, when this drug was researched,
it is mentioned that hydrolysis, the components within 12 to 24 hours do not exceed 10%. Therefore, its effectiveness is maintained, and it is distinguished probably by such a long hydrolysis period and its lesser
intensity, so to speak.
Yes, that is, to conclude, in principle, the answer, with proper storage and dilution. The preparation can remain effective for up to 10 days, showing good results throughout this period. So in principle, it seems we have answered this question with you. So, the next question, Maria Romanova. Stepan Stepanovich, Vesotil instructions say take antihistamines 15 minutes before and anticholinergics, diphenhydramine and atropine. Are you using this pre-medication?
No, I don't use it routinely. In general, perhaps it's like a advice from researchers alerting everyone to.
It seems to me that this is found in all instructions from all manufacturers of active substances and products containing these active substances. And there probably such a tradition comes from classical literature, which researchers must always be sure to reference. This means when you open anything. The WSAVA guidelines, it will state that it is possible the occurrence of bradycardia, potential allergic reactions, thus in case of general there is such a recommendation to use. To be honest, when I first began using Vezotil, I didn't even imagine returning to the roots of some kind of classical literature. I have ample experience with thialtamine and zolazepam in printed materials, with no occurrences of allergic reactions or bradycardia taking place during my extensive work with them. After the introduction of these medications, I have never seen. Therefore, personally, for me, this recommendation does not make much sense once again. This is a tribute to the bureaucracy in which we live, and there are certain requirements for the instructions that manufacturers must adhere to.
Most likely operating in mono mode, that's what I
Even in mono mode, I still would consider it a recommendation after all. Again, everyone here relies on their own clinical experience.
Yes.
Depending on the types of animals you interact with, you might find yourself working with zoo animals, particularly if that is your chosen field. And there is such an effect observed, that is, I work with cats and dogs, with ferrets and some other exotic animals, and expressed in such ways, side effects such as bradycardia or allergic reactions for which these medications should be used. Well, I haven't seen it, honestly. Moreover, I'll tell you, there's a recommendation about opioids. For example, the same thing is written in all sources. That bradycardia development is possible with intravenous administration. You need to use some atropines and antihistamines, because with this particular reaction is associated with the release of histamine. While I do not employ that specific method myself, I can certainly attest to this based on my own practical experience.
Yes, thank you very much.
Hello, my name is Tatiana. I work at the Matroskin Veterinary Clinic. I have a question for you. Do you dilute Vezotil to 5 milliliters? With Zolatil, we diluted to 10, then 20 milliliters.
Well, in Vezotil 2, I don't know if you've seen it personally. The vial there isn't very spacious. And if Zolatil allows this to be done, then essentially they pour into it. But to be honest with you, also, confusion arises because when you work in a large hospital, for example, in a major clinic, there are different people, anesthesiologists, who may not even know each other. To see things away from any kind of gatherings, and everyone has a different training level, different habits. Some breed to 10, some to 5, some to 20, and absolute confusion begins. So I still stick to diluting to 5 milliliters, and somehow it's already ingrained. Recorded that Zolite in a milliliter of Vezotil, 100 milligrams in a milliliter. Based on the two active ingredients, you accordingly need to add a certain number of milliliters to 50 to achieve that concentration. Would you like me to tell you, by the way, a bonus on how I dilute anesthetics so as not to give, for constant rate infusion, as I have already mentioned, a super favorite scheme, and often I use it in various situations. It's a mixture of 3 medications: dexmedetomidine, Vezotil, and lidocaine. That is, I choose such initial dosages. I'm going to make a break at this point, and as a result, I will simply inform you. Dexmedetomidine is 0.125 micrograms. This dosage seems appropriate as a starting point. Going below may not be effective, so I might as well just switch it off later. So Vesotil 1 milligram per kilo per hour, let's go with 2 milligrams per kilo per hour, and lidocaine.
This will be for us 30 micrograms per kilogram. For proper dissolution, we require a certain volume to be added within a specific time frame. And I do it so that this whole story is approximately, to use only one syringe, I require just 1 milliliter of medication. And accordingly, the calculation is like this. I take a 50 milliliter syringe and add to it these kinds of volumes. I take 1 milliliter of 10% lidocaine, 1 milliliter of Vesotil, and 0.1 milliliter dexmedetomidine, which we have 0.1, meaning there are 100 micrograms per milliliter. This is how I made a note here. If you calculate it, I won't calculate it right now, so we have 50 milliliters here. It will be in micrograms here.
2000 micrograms per kilo.
1 milliliter. And this will be approximately equal to 33 micrograms per kilogram per minute. So Vesotil will be here now.
We have 50. Help me divide 100. That will be 2 milligrams.
Stepan Stepanovich, you're doing great on your own.
Huh?
You're managing without help.
Yes. And here the last one we still have left is dexmedetomidine, so that comes out to
0.2 micrograms, yes, 1 milliliter.
That is, accordingly, we set the number of milliliters equal to the number of kilograms and get approximately our starting dosages. Therefore, you can train yourself in this manner and gradually improve.
Quickly gathered all of this, yes, especially if there's a situation, well, and there's always preparation time. Short, it is valued by surgeons and with the surgical team, you know, and if you need to slightly increase the dosage there, you can already play with this. Speed in the infusion pump, for example, so that's a little life hack, I don't know. Maybe it was useful to someone.
Yes, thank you very much. Thank you.
Well, the only thing is, I'll tell you another detail here.
If you have a large animal, it's clear that, or you don't want to, I don't know, a dog.
Well, basically, or if you want more infusion, then just subtitle, multiply by 2, by 4, by 5, that is like, or use less. So here already, to each their own. But this is a basic scheme, you know, one that requires no thinking.
Sometimes an anesthesiologist can afford to do that.
Yes, thank you very much. Thank you. Mike Ivanov, a question regarding the clinical case you described. Was the hippocampus used on this Yorkie and was furosemide administered after hippocampal?
Hypocapnia.
Sorry.
Indeed, hypocapnia was not utilized here, primarily because this particular approach in reality...
I understand, yes, what Mike is talking about.
Tell everyone, yes.
Yes, it is believed that in patients who are prone to brain swelling...
Therefore, are we talking about hypocapnia and hyperoxemia here? In other words, by increasing oxygen levels artificially, we aim to reduce CO2 levels, resulting in hypocapnia.
So that this metabolism kind of change and
to reduce the predisposition to brain swelling, it is currently not confirmed in medicine or veterinary science for humans.
I always aim for normocapnia and typically strive to maintain oxygen levels below 40% in my patient management. Mixtures, for example.
Well, that is, I believe that
there is no need regarding furosemide as well. I don't really consider it to be specifically one of those loop diuretics.
Are needed for this category of patients. They usually respond well to mannitol. You see, to osmotic diuretics, and according to the pathophysiology of all these mechanisms, their loop diuretics will have less effectiveness, But if there is such an approach, again, if mannitol doesn't help, yes, you can use furosemide instead. But I don't know. They are usually in some kind of unstable condition, so extra diuretics are sort of debatable, very debatable. In
Not to
my
overdo it,
opinion,
right?
yes, yes.
Basically, that's all yes, I think, on this question. Vetoptima. Has Vesotil become your number one drug? Or does your hand reach for analogs?
No, actually, I don't see like any particular values, say in the golden age, especially mine. And there is resentment towards him for their supply interruption and like the increased amount of gray hair like on my head, so I might refuse simply due to personal reasons, simply because in general they hurt me at some point.
Another question. You're Vetoptima, so are you now only using Vesotil? Or is there still a situation where I would administer this to a specific patient?
Zolitil? No, that's a resounding no from all of us. We completely understand. So veterinary medicine is a commercial field, right? And consequently, well, if Zolitil gives me a discount, then I'll reach out. Not yet. Yes, no.
Thanks for the reply. Another question. Abrosum sent this. Are there any data on the interaction of the drug with antimedin when used under compulsion?
That is, well, look, as for antimedine, in reality it should not reverse the effects in any way. Neither tyaltamine nor zolazepam, meaning it doesn't belong to this group of drugs. Yes, so the reversal here will occur precisely on that part. Side effects, which, well, and beneficial ones too, that will only occur with alpha-2 agonists. Since it's linked, treating a Vesotil overdose here using antimedine would not serve any purpose whatsoever, correct? And, well, there's the antidote for benzos, flumazenil, yes. Also, splitting the benzodiazepine from the tyaltamine would be a very bad idea, so I wouldn't do that. Well, and kind of usually if such a situation occurs where we are not satisfied with some kind of the impact, for example, on the animal in the context of our overall multimodal narrative here. There were instances of bradycardia or AV block due to dexmedetomidine causing concern. It's clear that dexmedetomidine is responsible for these effects, which are worrying to us. We proceed with caution during the reversal process, ensuring that analgesia levels do not decrease to a point where we must halt the operation due to extreme levels of pain. Or any new side effects. I haven't seen anything like that. Yes, well, and sort of maybe some other data, well, basically shouldn't interact with each other. So, and if this is a question about exactly the feature of Vesotil as a drug is what happens if you add antisedan to a cat that already has Vesotil. Will something coagulate in her? I don't know. Well, no, that's not the case.
Yes, but purely theoretically.
Indeed, there should be no physicochemical interaction between the substances. In a laboratory setting, they do not exhibit any interactions or tendency to precipitate. There's nothing like that.
Olga. Atropine, diphenhydramine, is that pre-medication? Why is the shift now toward other pre-medication agents?
I'll explain diphenhydramine like, well, honestly, tell me maybe, Olga, yes, that is also like, recall your experience there, anesthesia, in principle. For what purpose do we use diphenhydramine? That is, every pre-medication should have some kind of goal. Well, for each medication, that is, we have goals, that is indeed like an antihistamine effect, like a sedative effect. We use an antibiotic with you in pre-medication. Yes, we can use preemptive analgesia there. It will all be pre-medication. And the question for diphenhydramine, that is, if it is responsible here for what? For sedation, well, I'll say this. There are more modern drugs for sedation. That is, in my opinion, if he is responsible here for the antihistamine effect, well, to answer this question, how often have I seen specifically some kind of allergic reaction to medications? Yes, which are accompanied by, well, hypotension, bradycardia. Well, perhaps only regarding amoxiclav, if I'm being truthful. If Olga is currently using amoxiclav, there might be some sense to it, but we must consider the latest findings. Antihistamines should be taken only after we've had an allergic reaction. That's how I see things on this matter. We must be cautious and use them when needed. And why not atropine? If it causes some kind of tachycardia during pre-medication, living with tachycardia like a dog at 180 during the operation, and especially if you did it intramuscularly, right? Well, it will be very difficult, meaning you will have high blood pressure constantly, a high risk of bleeding, that is just a high metabolism in general, meaning higher doses of certain medications will be needed. You see, I'm not a supporter of such things, as it were. Adventures during anesthesia, tachycardia upon induction can be a problem for me, yes, especially if we consider the type of surgery, that is, on a mastectomy, which has a large number of vessels, where surgeons, that is, they ligate or coagulate there, if they are, so to speak, excessively bleeding during the operation because of tachycardia. Well, this could lead directly to failure, especially since, firstly, it's more precise, and secondly, if the animal has another condition, for example, a cat, who has hypertrophic cardiomyopathy, then yes, tachycardia is not just unhelpful for her, it can even be critical, therefore. Considering that, unfortunately, we do not always examine cats, yes, although we should. Well, the owners refuse, for example, there's no such possibility, that is, such things, again, once more. Side effects might not help us at all and could simply lead to a total disaster in the end. Hence, in cases of bradycardic episodes, I will administer atropine to carefully manage your patient's condition for optimal control when necessary. If the monitor or a blood pressure cuff is not available, you can check the patient's pulse by holding his hand over his heart. Although the monitor is typically used in the operating room, this alternative method can be used in its absence. BP monitor only used in operating room. I sense an issue, so I may begin administering atropine intravenously once bradycardia emerges. It's essential to act promptly in such situations. So, not preventively before that, I'm not a supporter.
Yes, Stepan Stepanovich, thank you very much for all the answers. You have actually conducted a wonderful lecture. You answered all the questions thoroughly. Our viewers have run out of questions. We thank you very much for your comprehensive and impartial answers. Thank you very much.
Thank you.
Thank you very much.